Dear colleagues, it is my great pleasure to be part of the Chilean Society of Adaptive Physical Activity Congress. And I am happy to share today with you my clinical and research experience in evaluating of autonomic dysfunctions in Paralympic athletes, particularly with spinal cord injury, that could affect their performance. I'm professor of rehabilitation medicine at the University of British Columbia. I'm also an endowed chair of rehabilitation medicine at the University of British Columbia. As well as a clinician, I'm working within the spinal cord injury unit of the largest rehabilitation center in British Columbia, known as GF Strong Rehabilitation Center. And also at the present time, I'm a president of American Spinal Injury Association. This association is combined clinicians and scientists who are involved in care and research in the area of spinal cord injury. Before I will start my presentation, I would like to disclose financial and research support that my laboratory received from various international and national agencies, and as well participation on advisory board for numerous pharmaceutical and industry partners. Specifically today, I will try to address some specific issue of autonomic cardiovascular dysfunctions that happening in individuals with spinal cord injury. And particularly, I will talk about how these autonomic dysfunctions could affect participation of athletes with spinal cord injury in a sport competition, and specifically my research during the numerous Paralympic Games. I will talk a little bit about very unique and interesting phenomenon known as boosting in individuals with spinal cord injury participate in Paralympic competition. And finally, I will try to give you some interesting perspective on some issues that we still have to clarify with respect of international classification when we are assessing Paralympians before the competitions. We do know very well that in general, when people coming to Olympic or Paralympics Games, the motto is Citius, Altius, and Fortius, faster, higher, stronger. And obviously, we're expecting that athletes who participate in Olympics and Paralympic Games are healthy, powerful, they're full of endorphins. Obviously, they're enjoying the competition, they're thrilled to be at the competition, and obviously the goal is to win. However, we also have to clearly realize that there is also pain and aches and tears involved in competitions, particularly when we're talking about elite athletes such as Paralympic athletes. Let's first of all answer one question. What changes occur in able-bodied individuals when we start exercising? We know very well there is requirements in the heart rate increase. There is also increase in arterial blood pressure, increase in respiration, increase in peripheral blood flow, particularly in a group of muscles which involved in a specific exercise. We also will produce sweat during exercise. And all these adaptive physiological changes in our body happening because muscles, peripheral structures involved in exercise has a higher demand for oxygen intake, for bringing nutrition in order to perform and compete during the competitions or do exercises. I also would like to ask you a question, what is different for individuals with spinal cord injury who are involved in exercise and sport competitions? First of all, we do know, and I will show you some data in a few slides later, that resting blood pressure in people with spinal cord injury, particularly with a cervical or high thoracic level of injury, resting blood pressure is lower than in able-bodied individuals. We also know that individuals with spinal cord injury or other neurological disorders could present with orthostatic hypotension, lower blood pressure when person trying to sit up straight or standing up. Finally, we do know that many athletes or individuals with spinal cord injury, when they exercise, they have paradoxical responses in their physiological responses to the exercise, such as decrease in arterial blood pressure immediately post-exercise, and it's known as post-exercise induced hypotension. There is also poor response in heart rate, and this is a level dependent, and I will talk about this a little bit later. And finally, there is a unique condition in people with spinal cord injury known as autonomic dysreflexia. It is sudden increase in arterial blood pressure up to 300 millimeters of mercury that could occur as a result of peripheral stimuli below the level of injury. And therefore, some of the athletes could utilize this increase in blood pressure to improve their low resting blood pressure that could potentially help with their performance. And this phenomenon of self-induced autonomic dysreflexia known as a boosting. And we'll talk a little bit more details about this. So this is what just general discrepancies of the autonomic cardiovascular controls that individuals with spinal cord injury are facing when they're trying to do exercise. We do know that autonomic nervous system is a very crucial component of our daily life. Balance between sympathetic and parasympathetic nervous system controlling practically every single organ. And this is particularly crucial for control of cardiovascular, heart rate, blood pressure levels, and so on. So where we'll start. Let's talk about cardiovascular control in general, what we do know from research and from clinical observations of abnormal cardiovascular control in people with spinal cord injury. I was fortunate to bring my students and my team, research team, to numerous Paralympic events, including starting from Beijing and until latest Pan American Games in Toronto. That's some research that I present to you, covering span of almost 15 years of participation on various Paralympic events. This is the members of my team during Vancouver Games in 2010. Then my team was in the London Summer 2012 Games. We also were participants in the Sochi Winter 2014. And as I mentioned to you last, my team was participated in assessment of Paralympic athletes at the Toronto Pan American Games in Toronto in 2015. Participation in the Paralympic Games for scientists, clinicians is extremely exciting. First of all, we're meeting athletes from all around the world who are extremely generous with their time and interest to participate in research related to Paralympic Games. We also meet interesting people. In addition to Paralympic athletes, Prince Edward visited our clinic at the Toronto Games. And I also had fortune to collaborate intensively with the Chilean Paralympic athletes. This is a Chilean team during the Toronto Pan American Games, and numerous physical therapists as well, physicians and Paralympic athletes, rugby actually, wheelchair players, participated in research which I present you today. Let's talk a little bit about the normal autonomic functions and organization of autonomic nervous system, which is crucial for our understanding how blood pressure and heart rate affected by spinal cord injury. Sympathetic nervous system, predominantly sympathetic preganglionic neurons, localized within the spinal cord between T1 to L3 region of the spinal cord. Parasympathetic neurons, which predominantly responsible only for the heart, localized within the medulla. Therefore, we do know that after spinal cord injury, mostly sympathetic nervous system affected. Parasympathetic nervous system is always preserved. Upper portion of thoracic spinal cord control heart rate sympathetically, typically increase heart rate, and also blood vessels in our upper portion of the body. Sympathetic preganglionic neurons from T6 and below control a large vasculature bed in our abdomen and our lower extremity muscles. And it is one of the largest blood vessel capacity regions that is crucial for maintenance of blood pressure when we're standing up. We need a vasoconstriction of the blood vessels in this region in order to maintain blood pressure. And as I mentioned, your vagal nerve or parasympathetic nervous system innervate with respect of cardiovascular control only heart. There is no blood vessel innervation by vagal nerve. Let's talk what's happening with a high cervical injury in individuals with spinal cord. As you can imagine, both heart and blood vessels are disconnected from supraspinal structures that are responsible for the tonic activation of blood vessels, tonic activation of heart rate. And typically we will see low blood pressure, inability of heart rate to respond to exercise. And we also know the higher level of injury to the spinal cord, more pronounced cardiovascular abnormal control in these individuals. In individuals with mid-thoracic spinal cord injury, for example, with T6 paraplegia, there is a big difference in cardiovascular control. As you can imagine, heart has normal control from the sympathetic and parasympathetic nervous systems. That's when people with paraplegia, we're expecting practically normal heart rate responses to exercise. However, due to large blood vessels in the belly, in abdominal region, we still could expect some abnormal blood pressure control after the with injury at the mid-thoracic level of injury. Lower the level of injury, less pronounced cardiovascular dysfunctions, and typically with injuries at T10 and below, we don't observe significant autonomic abnormalities in the cardiovascular control. Person with spinal cord injury at this low level typically present with practically normal cardiovascular control. And therefore, this will be crucial for us to discuss when we will talk about performance and associated blood pressure and heart rate regulations. This is data from my laboratory, and one of my junior colleague, Dr. Chris West, who is right now independent scientist at the Vancouver University, conducted research, and we look on the blood pressure levels of individuals without spinal cord injury control, as you can see, able-bodied, cervical, high thoracic, and low thoracic level of injury. As you can see here, when persons supine, people with cervical spinal cord injury have still very low resting arterial blood pressure. But people with mid-thoracic, low thoracic, and able-bodied control have normal arterial blood pressure. However, when person is seated up, both cervical individuals and high thoracic level of injury individuals presented with decrease in arterial blood pressure, consistent with orthostatic hypotension, and individuals with very low thoracic level of injury and able-bodied control were able to maintain normal arterial blood pressure with this orthostatic challenge test. And this is again crucial fact to remember, that typically people with a high level of injury have abnormally low resting blood pressure and also predisposed to orthostatic hypotension. This is one of the clinical example of orthostatic hypotension in one of my patients. When he is supine, his arterial blood pressure was very low. He has cervical spinal cord injury. You will see the blue line, it's a blood pressure, green line, mean arterial blood pressure, and purple line is heart rate recorded continuously. As soon as we tilt up to 60 degrees, typical orthostatic stress for person with spinal cord injury, his arterial blood pressure went down and his heart rate slightly elevated. This is a typical response of cardiovascular system to orthostatic stress when there is not enough power of sympathetic nervous system. Person also developed dizziness, lightheadedness, not surprisingly, as his arterial blood pressure was very low. As soon as we transfer person back to supine position, his symptoms disappear and his arterial blood pressure returned to pre-stress situation. This is an example of orthostatic lowering blood pressure during transfer to the tilt-up test. Another condition which I would like to introduce you visually is autonomic dysreflexia. This is a response in arterial blood pressure and heart rate in a young man with cervical spinal cord injury during penile vibrostimulation in order to obtain ejaculate. When the young man planning to become a father, we are helping with this procedure in order to assess quality of sperm. And we do know that many individuals with spinal cord injury, particularly cervical spinal cord injury, will develop this hypertensive crisis known as autonomic dysreflexia. At rest, 0.1, his arterial blood pressure was low, heart rate 82. As soon as we started vibrostimulation of his genitalia, his arterial blood pressure increased to 148 over 105 millimeters of mercury, and he showed bradycardia, typical parasympathetic response. And finally, at the moment of ejaculation, his arterial blood pressure tripled up to 240 millimeters of mercury, and he also developed arrhythmia. So this is a typical abnormal cardiovascular response to peripheral stimuli in the person with cervical spinal cord injury, and this hypertensive crisis we call autonomic dysreflexia. They're also occurring when persons have distended bladder, distended colon, or any irritation below the level of injury. We do know that from research from our laboratory, these events could occur up to 24 to 40 times, depending on the level of injury in the same individuals. And this is example of 24 hours blood pressure monitoring in one of the individuals with cervical spinal cord injury with frequent events of autonomic dysreflexia. We also look in animal models what's happening with vessels of the cerebral blood flow, particularly during this frequent episode of autonomic dysreflexia. And from this data, we demonstrated that blood vessels in a cervical spinal cord change dramatically, in the cerebral vessels change dramatically. They develop more collagen deposition, they become more rigid, and this predisposes individuals with spinal cord injury for, unfortunately, to bad cardiovascular events. For example, if arterial blood pressure increased above 150, which within the limit of cerebral autoregulation, person with spinal cord injury could develop hemorrhagic stroke. If arterial blood pressure going below 60 millimeters of mercury, person can develop ischemic stroke. And that's why these parameters from 60 to 150, we know below within the auto-regulation of our cerebral blood vessels that maintain good perfusion within the brain. Outside of these parameters, person can be in trouble. And we do know that these events unfortunately occur. This is example of hemorrhagic stroke in a patient from Spain. Colleagues from Spain reported this episode when person developed urinary tract infection, blood pressure was significantly elevated, and he developed stroke after the long life survival with spinal cord injury. Another example of bad consequences of autonomic dysreflexia, this is my patient in my clinical practice. These young individuals developed also urinary tract infections, and though his heart was in a perfect condition, no vasculature abnormalities due to high elevated blood pressure and severe coronary artery vasoconstriction during autonomic dysreflexia, he developed myocardial infarction. And so we have to be prepared for this abnormal and unpleasant consequences of autonomic dysreflexia. In order to summarize some bad and potentially good effects of autonomic dysreflexia, I would like to go with the next slide. First of all, we do know that consistent elevated blood pressure in people with spinal cord injury due to autonomic dysreflexia, similar to able-bodied individuals, result in negative impact on vasculature health. We do know that episodes of autonomic dysreflexia are life-threatening, and they can result in stroke or even death of individuals with spinal cord injury. We also demonstrated in our studies from our laboratory, but also colleagues from Bronx, demonstrated that episodes of autonomic dysreflexia or orthostatic hypotension could predispose individuals with cognitive dysfunctions. And finally, it is important to realize that sometimes episodes of autonomic dysreflexia, even with a very highly elevated arterial blood pressure, could be totally asymptomatic. And this is very dangerous. What about good effects of autonomic dysreflexia? Because many individuals with spinal cord injury do not have any sensation below the level of injury, sensation due to autonomic dysreflexia could be a warning sign that something wrong with my body. And that's why many of my patients can tell me, I know when I have urinary tract infections because I start to sweat, I will develop headache. And this is a sign of autonomic dysreflexia that give warning to person with spinal cord injury. I have to check my body. Interestingly, episodes of mild autonomic dysreflexia with some sensations represent some our patients with spinal cord injury started to perceive as a positive orgasmic sensation during sexual activity, because one of the devastating aspects of spinal cord injury, many individuals losing capacity to perceive orgasm. And finally, questionable issues, good or bad. As I mentioned to you before, if person with a low arterial blood pressure after spinal cord injury will develop episodes of autonomic dysreflexia or trigger this episodes of autonomic dysreflexia by himself, which is called boosting, these individuals can feel better because they have better health, brain perfusion, and some of them who participate in a competitive sport could perform better. But there are many dangerous aspects of this self-induce of autonomic dysreflexia, and I will address this later. How we presently evaluate individuals with spinal cord injury in a clinical condition. Present assessment, clinical assessment of people with spinal cord injury came from collaboration of two major organizations in the world that are focused on clinical and basic science research in area of spinal cord injury. One is American Spinal Injury Association, and I mentioned I'm at the present time president of this organization, and also International Spinal Cord Society, the second largest organization in the world. In collaboration between two organizations, we developed two major components of clinical assessment of people with spinal cord injury. First assessment is devoted to the evaluation of motor and sensory neurological deficit, known as international standards for neurological and functional classification of spinal cord injury, or known as INSCI. And second assessment devoted to assessment of autonomic dysfunctions, known as international standards to document remaining autonomic function after spinal cord injury, or ISAFSCI. That's therefore, clinically, we definitely realize that we cannot only assess motor and sensory function in people with spinal cord injury. We have to focus also on a variety of autonomic dysfunctions that could contribute to the various complications in people with spinal cord injury, developing of secondary conditions. How this assessment looks like. This is a typical standard form for assessment of neurological dysfunctions, including motor and sensory. I will not go through the details. I would like to mention only that Asia and ISCAS, we developed also Spanish and Portuguese version of this evaluation, and this available for free from the Asia and ISCAS website. And then second component is evaluation of autonomic functions. It is autonomic standard assessment that has components for assessment: heart rate, blood pressure, sweating, temperature control, and also assessment of pelvic organs, bowel, blood, and sexual functions. This is how booklets with explanation of this assessment presently looks like. We internationally update this assessment, and the latest assessment of international standards was completed in 2000, and the ISAFSCI was completed in 2021. I will highly recommend you to be familiar with these issues. From the clinical assessment of people with spinal cord injury, we clearly understood that motor sensory completeness of injury does not correspond to the autonomic completeness of spinal cord injury. People with a motor sensory complete spinal cord injury could have variety of autonomic dysfunctions that could dramatically affect their outcome. So this is what we know presently clinically. Let's talk about cardiovascular control in Paralympic elite athletes. And here I will present predominantly data from my laboratories that we obtained during the last 15 years. One of the largest studies we conducted during London 2012 Summer Games, when more than 64 Paralympic athletes came to our clinic, and we conducted comprehensive cardiovascular assessment with respect of their blood pressure, heart rate abnormalities, temperature control. And you see countries which were participated in our assessment. And I will acknowledge that there was a big interest of Paralympic athletes from Latin America in this study, and many athletes from Chile, Colombia, Brazil participated in this study. First, I would like to remind you how we're assessing at the present time athletes who are planning to participate in wheelchair rugby. As you know, it is a predominantly assessment of their neurological muscle functions. We do bench tests, functional trunk test, functional movement tests, and on-court evaluation. Based on this assessment, Paralympic athletes who participate in wheelchair rugby classification classified to the seven different classes, from 0.5, who has no hand function and they only grab a ball with their forearm, and they have poor trunk stability because they typically have very high level of cervical spinal cord injury. And the athletes who has full arm function, full hand function, and good trunk stability, some of them could be just amputees, or lower thoracic level of injury will have classification 3.5. As you know, the rule that on the court has to be total 4 athletes with a wheelchair, and their total score cannot exceed 8 points. That's my team made decision to examine Paralympic athletes within the rugby, wheelchair rugby, and we took and examined, first of all, I will present you data, athletes with a classification of 2. That is, they have the same international Paralympic classification of 2 with respect of their motor neurological assessment. When we look and examine their autonomic assessments using tilt table test, or what we call modified sit-up test, they were recorded their blood pressure, heart rate, and supine position, and then were seated immediately during the assessment, and we continuously record their blood pressure. We showed quite interesting data. If you can see athlete number 1, who has Paralympic classification number 2, had no drop in arterial blood pressure. His blood pressure during whole orthostatic stress was normal. Athlete number 2 demonstrated drop in arterial blood pressure. He was able to sustain blood pressure for 5 minutes of sit-up test. And as soon as we transferred him to supine position, his blood pressure recovered immediately. Athlete number 3, who also has Paralympic classification of 2, during tilt-up table test, his blood pressure dropped so dramatically, he became dizzy, lightheaded, and he was not able to sustain seated position. Test has to be interrupted. That's a conclusion from this part of our studies. We demonstrated that motor sensory assessment of Paralympic athletes who participate in a rugby wheelchair competitions based on our presently established IPC rules do not correspond to their autonomic blood pressure control. That's individuals who demonstrate low blood pressure, drop in arterial blood pressure, could be predisposed to lightheadedness, dizziness, fatigue much more than individuals who maintain blood pressure at normal level. So this is one of the important aspects of looking into the cardiovascular autonomic control in Paralympic athletes. Some of them could be at disadvantage. Next, we look on heart rate control, and both of these data already published from our laboratory. If you look on a red diagram, red line, this is the heart rate of individuals with amputation who is participate in a rugby competition, and individuals in a blue line with a spinal cord injury. As you can see, during the same events, during the same periods of rest or competition, individual with spinal cord injury was not able to achieve high level of heart rate in comparison with age-matched, sex-matched individuals without spinal cord injury. And this is one of the, again, even though their Paralympic classification was similar. So this is again the evidence that individuals with spinal cord injury have a diminished capacity to elevate heart rate, to improve their perfusion in different organs during competition, because cardiovascular functions are affected by the autonomic dysfunctions that develop after spinal cord injury. Before I was involved with Paralympic Games, there was a very interesting study, experimental study on a small group individuals, 8 athletes. Dr. Burham conducted this study, who were tested in boosted state with autonomic dysreflexia and unboosted state to perform a test. And what you can see here, in boosted state, individuals with spinal cord injury, typically blood pressure was elevated to 155. And what was interesting, that they were able to improve their athletic performance almost by 10% when they boosted versus unboosted. So this is one of the examples that obviously individuals with a very low blood pressure have disadvantage to compete during Paralympic Games. In terms of the athletes, try to induce autonomic dysreflexia causing boosting. Boosting is a type of doping that is discovered during Paralympic Games. It's act as deliberation to trigger episode of autonomic dysreflexia in order to increase arterial blood pressure, as I mentioned to you. It's achieved by various methods. Some individuals will drink a lot of water and they will not empty their urinary bladder before competition. Some of them will block their catheters if they have indwelling catheters, and this distended bladder will trigger autonomic dysreflexia, increase blood pressure, and athletes therefore improve and perform better. International Paralympic Committee in 1994 deemed boosting illegal and banned participants to use this method during competition. Furthermore, International Paralympic Committee developed a series of studies and screens right now for Paralympic athletes before competition in order to avoid boosting during the competition. One of the interesting aspects of my work with the International Paralympic Committee was related to the level of boosting that is allowed, level of arterial blood pressure that will be allowed to compete versus not allowed to compete. Initial publication by team of International Paralympic Committee allowed to compete individuals with arterial blood pressure around 180 millimeters of mercury. We discussed these issues with International Paralympic Committee. We presented some data from clinical work in our Paralympic assessment, and I was very pleased that in a after negotiation and discussions this issue with International Paralympic Medical Committee decided to decrease the level at which Paralympic athletes will be not allowed to compete to 160 millimeters of mercury. As I mentioned to you before, that after 150 millimeters of mercury, cerebral blood flow could be significantly interrupted and people could develop significant consequences. This is right now present recommendation from IPC. And in the last part of my performance, I would like to give you some interesting latest data, what's happening when individuals with spinal cord injury would like to increase their blood pressure in order to feel better. And there are new technological advances that allowed us to normalize arterial blood pressure in people with spinal cord injury, but it's still not yet addressed by exclusion or inclusion criteria for IPC and of course for competition. But this is what is coming. One of the aspects that we do know people with spinal cord injury right now can receive epidural spinal cord implant or transcutaneous spinal cord stimulation that could not only improve their motor function, but also improve their cardiovascular control. And I present you data from our collaboration with colleagues from Minneapolis, Minnesota. Dr. David Darrow is a principal investigator of this study. He's a neurosurgeon working in Minneapolis. And what we see here, this is a movement in individuals with complete spinal cord injury immediately after implantation. That's where we were able to achieve the presence or activation of silent motor pathways in person with spinal cord injury. And this, I'm sorry for the abnormal picture. This is again a woman with severe motor sensory complete spinal cord injury, participant of this trial in Minneapolis, who also developed improvement in motor functions after implantation. But what is exciting for my team was to observe improvement in autonomic control as well. And this is data from my laboratory. Dr. Chris West was first author of this paper together with Dr. Phillips and Dr. Square, trainees in my laboratory. We examined how blood pressure during the orthostatic stress test, which is familiar for you, will change with or without epidural stimulation. As you can see here in yellow line, arterial blood pressure and cerebral blood flow decreased dramatically when person was put into this vertical position at 60-degree test. However, with epidural stimulation on blue line, you see right now that we were able to normalize arterial blood pressure and cerebral blood flow. Therefore, patients did not develop episodes of orthostatic hypertension. And we also demonstrated that cognitive function improved during this procedure. Therefore, in general, improvement of autonomic control of arterial blood pressure could provide benefits for other functions of person with spinal cord injury. And the last paper I would like to demonstrate to you, this is data paper published in collaboration with Dr. Nightingale, who is right now a lecturer in Birmingham University, UK. When we look on VO2 peak in individual with spinal cord who perform exercise on arm bike before stimulation and with various parameters of stimulation. And as you can see here, with epidural stimulation on, he was able to dramatically improve his VO2 peak as a result of normalization of his cardiovascular parameters. So this is an interesting ergogenic effect of possible spinal cord stimulations that will activate not only motor, but also autonomic control in people with spinal cord injury, and they can perform better. Their fatigue less, their arterial blood pressure is in perfect state. I would like to conclude my talk with following. We do know that cardiovascular control following spinal cord injury at rest and during exercise is significantly disrupted. There is a need for stronger guidelines on blood pressure monitoring after spinal cord injury in clinical environment and during the sport activities. We still in need to find of solution, pharmacological or non-pharmacological measures to restore abnormal cardiovascular control in people with spinal cord injury, because this abnormal fluctuation of arterial blood pressure in people with spinal cord injury negatively impact their daily life, their functioning at work, and also, as I demonstrated to you, negatively impact their participation in sport. We continue to work closely with the International Paralympic Committee in order to further educate Olympic athletes, Paralympic athletes, coaches, their families, that boosting is dangerous and it is prohibited and it's possible harmful for your health. And definitely there is a strong need for inclusion of autonomic assessment into the International Paralympic classification in order to improve disadvantages, to eliminate disadvantages that some of the Paralympic athletes, particularly with spinal cord injury, could have during performance, during their abnormal cardiovascular control. I would like to conclude my talk. Thank you to all my students who participate during the numerous years of our research in the area of Paralympic sport, and of course, multiple agencies that support research in this area. Thank you very much again for the invitation, and I will be happy to answer questions. Thank you.